Welcome to our video series on how to be a good doctor. Today we'll be discussing interpretation of ECG, and this is part 5. My name is Dr. Iresha Gunasinghe. I am a consultant cardiologist from California. So my mission is to teach you to interpret a stat ECG confidently, comprehensively, and real quickly, especially if you had an unstable patient that you had to take care of. So one of the most important things I have been highlighting is that you have to be methodical. The first thing you are going to check is the rate. Next, the rhythm. Third, the axis. And then you are going to study each of the waveforms, starting with the P wave, PR interval, QRS complex, ST, and T. And today we will be focusing on different arrhythmias. And before you can do that, you have to learn a few terms. So one of them is supraventricular, which basically means above the ventricle, or another way of saying is that arrhythmia is arising in either the left or the right atrium. Then you have a ventricular, which implies that the arrhythmia arose in the ventricle, and somewhere around the AV node, we call it junctional. So supraventricular, junctional, and ventricular. How do we know if an arrhythmia arose in the ventricular area, or whether it arose in the supraventricular? It's very easy, because if it is supraventricular, the QRS complex is very thin, okay, and it will be similar to the patient's normal QRS complex. Whereas if it is ventricular, it will be wide and will be different from the patient's own QRS complex. So this is a good example. You see the patient's QRS complex, and then you see this big abnormal looking bead. Okay. Now a couple more words. So now we know supraventricular, it will be a thin QRS complex. And another word you'll hear is premature, which means it came early. Atrial means obviously it came from the atrial complex or contraction. So we also call it PAC. Now let's look at this rhythm strip. So you have a normal QRS complex here with a P in the front and a thin QRS. Normal, normal, and then you see a beat that's a little bit earlier than a normal one would be. So hence the reason it's called premature. And we know because the QRS complex is the same and it is thin, that this arose in the atrium, and contraction is contraction. So this is a PAC. Now let's look at a PVC, which is premature ventricular contraction. There you will see a wide QRS, which is not like the normal QRS of the patient. Here we go. So you see a normal thin one, and then you see the QRS that's wide. Okay. I want to also share one other concept with you, which is when you get a PVC or a premature ventricular contraction, there is a slight pause before the heart starts going back to its normal heartbeats. And during this pause, blood keeps coming into the atria and to the ventricle. So the next normal beat has a lot of blood in the left ventricle, and sometimes the patient actually feels that. So if they come and tell you that I feel my PVCs, premature ventricular contractions, actually what they are feeling is the beat, the normal beat after the PVC. Okay, and so that's one concept I needed to share. And the other is one other word, extrasystole. It's self-explanatory. It basically means extra beat. Now let's dig in deeper. Let's look at all kinds of ventricular beats and different names. So the first one is premature ventricular contraction or PVC. Now we know this is a normal beat because there's a P wave and a thin QRS, another normal beat, and then you get the premature ventricular contraction, right? Then you see another normal beat, and then you see another funny beat, which is wide. So we know that 2 is a premature ventricular contraction. But if you notice on this patient, that patient has got one PVC here and one here and another one here, right? But the shape or the morphology of each one, these two are different. So then we use this word, multifocal. Implication is that they arose in two different areas of the ventricle. Because if it arose from the same place, it will have the same morphology or the configuration. Okay, so now you learned another word, multifocal premature ventricular contractions. Okay, the next concept is bigeminy. What that means is you have one normal beat followed by a PVC, one normal beat followed by a PVC. And this pattern is called ventricular bigeminy. Next concept is couplets. What that means is you have more than one PVC happening together. So if there's two, we call it a couplet. And if there is 3 beats or more, we call it ventricular tachycardia. So here you get a couplet, and here you get 4 of the PVCs, one after another. If it is more than 3, we call it ventricular tachycardia. Okay, so you learned a whole bunch of new words. Next, let's talk about tachycardia. What does that word mean? It means a fast heart rate. Okay, it doesn't mean we don't know where it is originating. Now, it could be a normal sinus rhythm that is going fast, then we call it a sinus tachycardia. Let's see with how we figure that out. You see a P wave, right? And then followed by the QRS. Now remember our rule, we always start with the rate. So we look at two QRS complexes. So 1 square would be 300 beats per minute and 2 squares will be 150 beats per minute. So this rhythm is going at 150 beats per minute. Next, we check the rhythm, right? Rate, rhythm. And you see that that's pretty regular. So far we know it's a tachycardia that's going at 150 beats per minute and it is regular. Next, we look to see whether there's a P wave. And guess what? There is a P wave in front of every QRS. So we know that this rhythm arose in the SA node. So then we call it a sinus tachycardia. Okay. Now, in contrast, let's look at this one. First, we check the rate. So 300, 150. So that too is, the rate is 150 beats per minute. Next, we check to see whether it's regular. And it is regular. So the third thing we check is the P waves. And we can't see any P waves. So we immediately know that this didn't arise from the sinus node. Next, we look at, since we can't look at the PR interval, we look at the QRS. And the QRS starts here and ends here, right? And it is very thin. So thin QRS means it arose in the atria, so we call it supraventricular. And because it's going real fast, we call it a supraventricular tachycardia, okay, or a SVT. Now, you might think, why can't I call this a P wave? Well, if you follow this QRS, this is the ST, right? And therefore, this has to be the T. Look at this one. See the difference? This is a P. So this is the ST and the T. Okay. Now let's look at this one. The moment you look at it, you kind of get your adrenaline pumping, but you need to take a deep breath and go through the same sequence. So the first thing you check is the rate. It's about 1 square, which means it's going at about 300 beats per minute. That's pretty fast. And rhythm seems to be pretty regular. And then we look for P waves. Can't see any P waves there. Next, we look at the QRS complex, and it is huge. So we immediately know that this QRS complex came from the ventricle. Okay, so we have a ventricular tachycardia because it is going fast. Okay, so ventricular tachycardia or VT. So the trick is you just need to focus on that sequence and everything will fall into place. So this is a sinus tachycardia. This is a supraventricular tachycardia or SVT, and this is a ventricular tachycardia or VT. Okay. Now I want you to spend a little bit of time and go through this rate, rhythm, axis waveforms on your own and come up with your own conclusions. Okay, this is a supraventricular tachycardia. Now I need to share another arrhythmia called atrial flutter. Now this is a very common exam question, so you really need to know this. Look at the baseline and you see this sharp, we call them sawtooth rhythm, and it is very clear. These are arising from the atrium and we call them flutter waves, okay? And they keep going and going. Next, just like we do always, we should check the rate. So this is 300, 150, 100. So this rate is 100. And then we check to see whether it's regular or irregular. It's pretty regular. And then we look for P waves. These are actually arising from the atria, but they are not arising from the sinus node. So you have to remember this pattern and know immediately that this is a atrial flutter. There is one more concept I need to teach you, and that is not every flutter wave goes all the way into the ventricle. So in this case, there is one flutter wave, the second flutter wave, and that went through into the ventricle. So we call it a 2 to 1 block. And if you look here, you have 1, 2, 3, and it's the third one that went into the ventricle. So that's called a 3 to 1 block. And here you get 1, 2, 3, 4, and then a QRS. That will be called a 4 to 1 block. And if the block is variable, we call it a variable block. And then the rhythm will become irregular. If it is always 2 to 1, the rhythm will be regular. Okay? But this is atrial flutter. Next, let's look at atrial fibrillation. Now, this one, I really want to read it with you. So, the first thing we do is check the rate, right? So, 300, 150, 100. So, the rate is 100. And then we check the rhythm. Now, we have a rhythm strip here, right? So, that's the lead 2. And then initially when you look up here, it looks pretty regular. But when you come here, you realize that's why you need a longer strip, that it is not regular. Then we cannot use that system of 300, 150, 100. We have to count 6 seconds, and I did this already for you. And then count the number of QRSs in that 6-second area. So there is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then you multiply it by 10. So because it's 6 seconds here. So that will be 110 beats per minute. Okay. So we know the rate. We know the rhythm is irregular. Next, we look at the axis, right? So it's up in lead 1, equivocal in 2, and down in 3. So it's the axis is more towards the 1, and that would be a left axis deviation. The next thing we look at is the P wave. So the best place to look for P waves is in lead 2. And I cannot see any P waves. So we know that the P waves are not there, in which case there won't be a PR interval. And then we look at the QRS. So when you look at the QRS, it is 10. So we know this patient doesn't have a bundle branch block, right? Next, we look at the ST and the T. And remember, I told you it's good to look at this part together along the artery. So this is the circumflex artery distribution. So we check there's the QRS complex and the ST seems okay and the T is okay. So this one is all right. Next we look at the AVL, QRS, ST. The T is a little flattened, so we can talk about it, but really nothing big stands up. Next, we look at this group together, 2, 3, ABF. This almost looks like a Q, right? This one we already looked at. So, but if you really look carefully, there is a tiny little blip up. So this is not a Q, this is a S. So STT looks all right. Here again, a tiny little R, a deep S, STT looks all right. So the inferior wall is okay. Then we come here and then starts looking at V1 and V2. So R, S, STT, fine. R, S, STT, fine. So we know the septum is okay. Next, we look at the anterior wall. Again, the same thing. QRS, STT looks all right. QRS, STT looks all right. That would be the anterior wall. And this is the lateral wall. again looks all right. And the last thing we do is check to see whether the R here and the S here looks huge, and it is not. So we know the patient doesn't have left ventricular hypertrophy. Now, so far what we learned was this patient has a rhythm which is 110 beats per minute, and it is irregular. Since the QRS is um, thin, we know that this rhythm arose from the atria, and hence irregularly irregular rhythm is called atrial fibrillation. Now I need to share another arrhythmia, which is another ECG pattern, which is WPW, or Wolff-Parkinson's and White syndrome. And in this one, what you see is you get the P, but the PR interval is very, very short. You can hardly see it. And the QRS does this funny bit weird looking thing before the actual QRS begins. And this funny upsloping thing is called a delta wave. Okay. And let's see why a person will get a delta wave. So, in a normal person, the heart rhythm originates in the SA node, then it gets to the AV node, and then comes down the bundle of His, right? So, as it originates, you get the P wave, right? And then there is a delay in it coming into the ventricle, and that delay is the PR interval. And then once it reaches the ventricle, you get the QRS complex, right? Now, some of us have these accessory pathways or communications that shouldn't be there between the atrium and the ventricle. When that is there, let's say you had a beat originating in the SA node, the electrical current comes down. Now, apart from going down the AV node, which takes a little while, now you have a highway directly into the ventricle. So, before this current goes, this one really goes fast. Hence the reason you lose the PR interval, because these things are very fast. Okay, and that gives rise to the delta wave. So this is how you get that delta wave. Now let's look at a real ECG with WPW. So I'm not going to read the whole ECG, which I urge you to do, but all I want to show you is on lead 2, you see the little blip, that is your P wave, but you hardly see a PR interval, and the QRS looks weird. And it's kind of upsloping, right? That is the delta wave. So if you get a short PR interval, your mind should go and think about WPW. The reason why you need to know about WPW is something bad can happen. What is that? So here is the SA node. A current comes through to the AV node and gets into the ventricle, and then through the accessory path it can go back into the AV node and create a re-entrant tachycardia. Okay, or the opposite can happen, which is you get the SA node and the current goes through the accessory pathway and gets back into the AV node and creates a re-entry that way. Either way, you are going to end up getting a very fast heartbeat. Okay, now I want to share, before I share the next ECG, I want to tell you one golden rule. You should always look for old ECGs, okay, and compare with the current ECG. And let me show you why you need to do that. This is a patient As you can see, you have the P and then the delta wave and the QRS. So this is a patient that we know has WPW. It's very nice here. See, short, the P and then no hardly any PR interval and the delta wave. So if you were in the ER and a patient came with this, it is actually a supraventricular tachycardia, right? Its QRS is thin and it's going like crazy. Now, if you had known that the patient had WPW, then you would know that this is from the re-entry mechanism. Okay, and this is important in the management of this patient. So, hence the golden rule. Always look for old ECGs and compare with the current ECG if you can. All right, next concept. Now, we know from the past that this is a tachycardia running at about a rate of 300 and the QRS complex is huge and it's regular. So we know from the past that this is a ventricular tachycardia. Now you have to remember this. You hardly ever see it, but you will get a question on this most of the time. It's called torsade. And you get this pattern. Okay. So remember this pattern and know what it is called. It's a form of ventricular tachycardia. Now, let's look at this ECG. What is the first thing you notice? Now, remember our sequence. First, we have to try to figure out the rate. You cannot see any proper QRS anywhere. It's like a little child came and just drew a line and you cannot see anything, right? So this is ventricular fibrillation, as opposed to ventricular tachycardia, where you can, if you really pause for a second and go through your system, see that each one is a very regular and a wide QRS, as opposed to this mass. This is ventricular fibrillation. So you learned a whole bunch of stuff. And congratulations, now you need to build up on this, okay? Go and look at this many times and understand all these rhythms that you learned today. And let me summarize how to read an ECG. So first, you always check the rate. Next is rhythm. And then you look at the axis. In the waveforms, the best place to look at the P and the PR interval is lead 2. So you focus your attention to lead 2. Next, you look at the QRS complex in lead 2. If it is wide, then you have to make a determination whether it's left bundle or right bundle. And the easiest place to look at that would be lead 1. Okay. And next, you look at the ST and T along with the QRS complex. And for that, you follow the coronary artery distributions, which is 1 AVL together, 2, 3 AVF together, V1 and V2, V3 and V4, V5, and V6, right? And then the last thing you do is you check the V6 and V1 and see whether the patient has LVH. When you are looking at the rhythm, you should be able to figure out whether it's regular or irregular. I forgot to tell you that. So this is the sequence, and please write this down, keep with you, and whenever you get an ECG, check this. And the more you do it, the quicker you and better you will become. Hence the reason you need to practice, practice, practice. Okay. And always remember to compare with the old ECG. That's how you will know whether there are new changes. So I sincerely hope that you will be a good doctor and you'll be helping people in need without expecting anything in return. And remember the qualities of a good doctor and work on them every day. I want to wish you the very best and I want to thank you for listening. And please do take a moment to share this with your friends.